All right, let's put on our robes and step right into the courtroom of medicine. Consider me your medical judge for the day. We're here to conduct a strict, uncompromising clinical audit of high-stakes pediatric cases. Because, let's be real, in the fast-paced environment of the wards or the high-pressure vacuum of your board exams, pediatric presentations are an absolute minefield of signal versus noise. You're constantly handed overlapping symptoms, super vague histories, and terrified parents. So today, in this explainer, we're going to zero in on the exact tipping points to separate one crucial diagnosis from another.
Okay, let's dive right into this, because the cost of missing these diagnostic tipping points, it's absolutely massive. In the adult world, you might have hours to sit back and contemplate a diagnosis, but in pediatrics, missing the subtle difference between an upper airway structural narrowing and a lower airway obstructive process, or confusing an anatomical fracture with a mechanical subluxation, leads to catastrophic mistakes. We're talking wrong treatments, devastating outcomes, and entirely avoidable disasters. This explainer is designed to completely rewire how you look at these high-yield scenarios.
Here is our clinical docket for today. Number 1. Elbow vectors and tipping points. Number 2. The 6-month temporal wall. Number 3. The whoop versus the whistle. And finally, number 4. An executional pearl on a specific immune defect. Let's get started.
Section 1. Elbow vectors and tipping points. Let's call the orthopedic cases to the stand.
Picture this classic 50-50 dilemma. A frantic parent brings in a toddler who is flat out refusing to move their arm after a fall, or maybe after being pulled up by the hand. The kid is just holding the arm, completely immobile. Now, the clinical lawyer in you might immediately panic and order a 4-view X-ray series. But as the judge, I demand a strict audit of the mechanism of injury and the physical posture of that limb. Are we looking at a fracture or a subluxation?
Let's contrast these two pathways. On one side, you have the supracondylar humerus fracture. Evaluated using the Gartland classification, this is a true orthopedic emergency. The tipping point here is an extension-type displacement. See, the posterior displacement of that distal fragment severely threatens the brachial artery and the median nerve, specifically the anterior interosseous nerve. When you audit the X-ray, you're hunting for an occult fat pad sign or an abnormal anteriohumeral line. Now, on the flip side, you have nursemaid's elbow. This isn't a broken bone at all. It's purely a mechanical subluxation. It happens when sudden axial traction, like yanking a child's arm to lift them over a puddle, causes the annular ligament to become trapped right in the radiohumeral joint. The X-rays, characteristically, perfectly normal.
And this brilliantly illustrates exactly what we're dealing with in nursemaid's elbow. Because of that trapped annular ligament, the child is going to hold their arm in a pronated, slightly flexed position. And here's the kicker, they aren't actually crying in agony unless you try to move it. So what's the definitive execution? Immediate manual reduction. You don't need a surgeon for this. You execute either a hyperpronation maneuver or the classic supination flexion technique. You just apply pressure to the radial head, supinate the forearm, flex the elbow, and boom, you'll feel a satisfying click. Literally within minutes, the child is happily playing again. Which brings us to the very first dumb mistake on our docket. Do not order extensive X-rays when the clinical signal clearly dictates an immediate manual reduction. If you've got a clear history of a pulling injury and a child with an immobile, pronated arm but zero massive swelling or point tenderness over the distal humerus, ordering multiple X-rays is just noise. But you have to beware the inverse. Attempting a reduction when the child actually does have swelling or severe point tenderness is a massive error. That is a supracondylar fracture until proven otherwise. If the X-rays are negative but swelling is present, splint that arm and reevaluate.
Moving on to Section 2, the 6 months temporal wall. Let's dismiss the orthopedics and call immunology to the stand, shifting our audit down to the cellular level.
In pediatric immunodeficiency, you're usually handed a massive, totally confusing list of recurrent infections. But the absolute most critical question you can ask, the one that simulates the highest pressure of a board exam, is simply, when did the very first infection happen? The timeline itself holds the verdict.
We call this the 6-month temporal wall. For the first few months of life, a baby is shielded by maternal IgG antibodies that cross the placenta. So, if a child presents immediately between birth and 3 months with failure to thrive, chronic diarrhea, and widespread thrush, you're looking at severe combined immunodeficiency, or SID. But if the child is totally healthy for the first 6 months and then suddenly starts getting recurrent cynopulmonary infections with encapsulated bacteria, you've crossed the temporal wall. That maternal IgG has waned, unmasking Bruton's A-gamma globulinemia.
So the crucial point here is understanding the hierarchy of the immune system. SCID is a total collapse.
T cells are the generals of the immune system, right? Without them, B cells can't function either, which leads to this incredibly broad vulnerability to viral, bacterial, and fungal invaders. Bruton's, on the other hand, is an X-linked recessive pure B cell defect caused by a BTK gene mutation. The pre-B cells just failed to mature, but their T cells, they work perfectly fine. Because it's a pure B cell issue, a brilliant physical exam clue for Bruton's is literally an absolute absence of tonsils and palpable lymph nodes.
I'm issuing a strict warning here. Do not confuse the scope of vulnerability between these two. A child with Bruton's can actually still fight off a lot of fungi and viruses because their T cells are intact. A child with SID cannot, and they absolutely require a definitive bone marrow transplant to survive. And you know the absolute dumbest mistake you can make? Administering live attenuated vaccines like rotavirus, varicella, or MMR to an infant with suspected SID or Bruton's. In these immunocompromised hosts, those weakened viruses will cause disseminated fatal disease. Don't do it.
Section 3. The whoop versus the whistle. Let's move to the pulmonology docket to evaluate high-velocity coughing versus obstructive inflammation.
First up, let's examine the structural evidence. Notice that sharp narrowing of the upper airway? That's the classic steeple sign of croup, caused most commonly by parainfluenza virus type 1. When you hear an inspiratory stridor, that harsh, barking, seal-like cough, you are listening to upper airway subglottic narrowing. The airway is structurally inflamed right below the vocal cords.
Let's contrast this. Croup is your upper airway subglottic narrowing. But what if the child is wheezing with crackles, showing respiratory distress that peaks during the winter months? That's the whistle of bronchiolitis, heavily driven by respiratory syncytial virus, or RSV. This is a viral inflammation of the tiny lower bronchioles in children under 2 years old. And just to complete our sound profile here, if you ever hear a high-velocity paroxysmal coughing fit followed by a massive inspiratory whoop and then post-tussive emesis, well, that's pertussis. It's a toxin-mediated disease marked by profound lymphocytosis because the toxin literally blocks lymphocytes from entering the lymph nodes. You absolutely must be able to instantly differentiate the bark of croup, the whistle of bronchiolitis, and the whoop of pertussis.
Now, what's the critical error you can make here? It's failing to anticipate life-threatening apnea in young infants suffering from RSV bronchiolitis. These very young infants are at an incredibly high risk for just suddenly stopping breathing. Another major execution gap, trying to use albuterol or corticosteroids to treat that RSV bronchiolitis. Large-scale trials show zero benefit for these interventions in the primary treatment of the disease. None. The correct execution is purely supportive care, nasal suctioning, hydration, and supplemental oxygen if their oxygen saturation dips below 90%. Do not overcomplicate the whistle.
Section 4. Executional Pearl, Immune Defect. I've prepared a high-yield closing argument to reward you focused learners who have stayed with me.
Here's a really tricky board-style scenario for you. A young boy presents with recurrent, severe skin, liver, and lung abscesses driven heavily by catalase-positive organisms. Think Staph aureus, Serratia, and Aspergillus. But when you test his lymphocyte counts, his B cells and T cells are totally normal. The defect isn't in the lymphocytes at all. You order a nitroblue tetrazolium or NBT test and it comes back completely negative. What on earth are you looking at?
Now, what's really fascinating about this is the mechanism. This is chronic granulomatous disease, or CGD. The defect here isn't in the antibodies, it's in the burst. These patients have an NADPH oxidase deficiency. Their neutrophils arrive at the site of the infection just fine, but they simply cannot produce the superoxide radicals, the oxidative burst, necessary to actually kill the pathogens. As a result, they get entirely overwhelmed by those catalase-positive organisms. That negative NBT test, or an abnormal dihydrorhodamine flow cytometry test, basically proves the neutrophils are firing blanks. They're going to require lifelong prophylaxis with TMP-SMX and itraconazole just to survive.
And with that, I rest my case. We've audited the mechanics of the elbow, we've scaled the 6-month immunology wall, decoded pediatric respiratory sounds, and isolated the neutrophils' missing burst. So my final question to you is this. After everything we just went through, are you ready to confidently separate the true clinical signal from the noise on your next shift or your next exam? The tipping points are there, you just have to know exactly where to look.